Acute liver failure, or ALF, has passed by many definitions. The first one was defined by Trey and Davidson in 1970 as a potentially reversible condition, the consequence of severe liver injury with an onset of encephalopathy within 8 weeks of the appearance of the first symptom and the absence of any pre-existing liver disease. And then in 1993, the syndrome was redefined, taking into account the etiology, frequency of complications, and prognosis. It was divided into 3 categories, depending on the duration between the first symptom, which is usually jaundice, and the development of hepatic encephalopathy. If the duration is within 7 days, so this is hyperacute liver failure. If it's within between 8 and 28 days, this is acute liver failure, while if it's the duration between jaundice and hepatic encephalopathy is from 5 to 12 weeks, so this is subacute liver failure. If the disease duration is more than 28 weeks, so this is another entity, this is a chronic liver disease. Again, another definition was introduced by the International Association for the Study of the Liver in 1999. They have the same classification of these categories, but with different duration. If it's more than less than 10 days, this is hyperacute. From 10 to 30 days, this is fulminant liver failure. And if the duration between jaundice and hepatic encephalopathy between 5 and 24 weeks, so this is subacute hepatic failure. As we see here from this figure, we can find that the classification of the different categories of acute liver failure is not fixed worldwide. For example, here in the Japanese consensus, we can find that they have a different classification from the previous definitions. They classify it into fulminant and late onset. And the fulminant again is reclassified into acute and subacute presentations. So what is the difference and what is the importance of these categories? The hyperacute presentation consists of severe coagulopathy, markedly increase in serum transaminases, and the bilirubin elevation is not so high. So hyperacute presentation have a much greater chance of spontaneous recovery, although it looks clinically bad. It has significant extrahepatic organ failure, but usually these patients have more chance for spontaneous recovery. While subacute or subfulminant presentation have a milder increase in serum transaminases, the jaundice here is usually more deep, and there is mild to moderate coagulopathy. And here the patient, once he develops hepatic encephalopathy, even if it's minimal, these patients will have a very low chance of spontaneous survival. It should be noted also that the serum transaminase level is not considered as a fully reliable parameter for diagnosis, so we don't usually depend on it. And another important point that the hyperacute and acute syndromes are usually easily diagnosed, while subacute ALF sometimes mistaken for cirrhosis because they have many radiological signs mimicking cirrhotic patients. They have splenomegaly, they have ascites, and shrinkage of the liver volume. So if we mistake the diagnosis of these patients and we think that they are chronic patients with cirrhosis, this patient may lose his opportunity to be considered for liver transplantation. Another importance of these categories is not just important for prognostic value, but also they are related to some etiologies. From this table, we can find that, for example, viral hepatitis, one of the most important causes of ALF, usually the presentation is acute or fulminant. In cases of paracetamol overdose, the presentation can be acute or subacute in some cases. In cases of Busch-Chiari syndrome, the presentation can be acute or subacute. In cases of hypoxic hepatitis, it is usually fulminant, and so on. So what about the prerequisites that are needed to diagnose these conditions? We have 3 prerequisites. The first one is coagulation disturbance. This is very important to define ALF, and we depend on the prolongation of INR. It is, if it's more than 1.5, so this is considered ALF case. And we have to transfer this patient immediately to a specialized unit. But although this is still, till now, is a point of debate, the figure of INR still is a point of debate, and it could be argued that a greater prolongation of INR should be required to define ALF and needs further researches. The second prerequisite is jaundice and hepatic encephalopathy. However, we have to know that in very young children and neonates, ALF may occur in absence of hepatic encephalopathy. The initial mental alterations may be minimal, and we have to actively try to find them. Efforts have to be made to develop more sensitive measures to define early grades of hepatic encephalopathy, because if we diagnose them early, the prognosis will be better, of course. And the concept of minimal hepatic encephalopathy, we know it is very recognized in patients with cirrhosis and has many tests that are very known, such as psychometric tests and so on, but this is poorly characterized in patients with ALF. The last prerequisite for diagnosis is absence of any previous severe fibrotic or cirrhotic chronic liver disease. But still there are some exceptions, like the patients with acute de novo presentation of autoimmune hepatitis and Budd-Chiari syndrome. So these patients, they have underlying chronic disease, but usually have not been diagnosed previously, and there is no clinical or histological evidence of cirrhosis, so they are classified as ALF. Another exception is Wilson disease. This is a clear chronic liver disease with splenomegaly in most of patients, but frequently undiagnosed, and the first presentation is acute presentation, and they have a very similar clinical picture to ALF. The last exception is those patients without overt fibrosis, but still they have evidence of liver pathology, such as those with hepatitis C or B, those with fatty liver, they have a pathology, but sometimes they may be supposed to any acute liver injury, and then they develop acute liver failure. These are some clinical points that can help in diagnosis of the cause of ALF. The most common cause, especially here in Egypt, is viral hepatitis. And the most common are hepatitis B, A, and E viruses. The most common one of them actually is hepatitis B virus, can cause severe ALI, acute liver injury, and then followed by acute liver failure, either due to de novo infection, delta superinfection, or reactivation in a patient with previous HPV infection. This condition happens in fewer than 4% of cases with acute hepatitis B, but the mortality in these patients is higher than those with hepatitis A or E virus infection. And early treatment with antiviral therapy in these cases will decrease the risk for progression to ALF. Hepatitis A virus is less common than B. It occurs in less than 1% of patients with acute hepatitis A. The presentation usually is hyperacute or acute clinical course. It has usually worse prognosis in all patients. Hepatitis E, it results in hyperacute pattern of ALF. The mortality usually is low, but has worse outcomes if it's observed in elderly patients, in those with pre-existing but undiagnosed chronic liver disease, and especially in pregnant females. We have also other viral infections, non-hepatotropic viruses that we have to search for if the ALF etiology is not clear, like herpes simplex virus, varicella zoster, cytomegalo virus, Epstein-Barr virus, especially in immunocompromised patients. The second most common cause of ALF, and considered as the first common cause in Europe and USA, is paracetamol overdose. This condition characterized by very high levels of aminotransferases. Usually the bilirubin elevation is not so high. Rapidly progressive disease with multiple organ affection, especially renal impairment and metabolic acidosis. Usually the needed dose to cause ALF is more than 10 grams. But we can find that some patients are more sensitive to paracetamol and they need less doses to develop acute liver failure. Those patients with decreased glutathione reserve, because glutathione is needed for metabolizing paracetamol, like patients with prolonged hours of fasting, excessive alcohol consumption, those patients that are taking certain regular medications such as phenytoin. All these conditions can decrease the glutathione reserve. So at admission, a toxicology screen and determination of the paracetamol level is very necessary in every patient, although the levels will frequently be negative. That's why the EASI guidelines stated that if the patient already has coagulopathy and increase in serum transaminases, we can give him, even if the serum is negative for paracetamol, we can give him N-acetylcysteine therapy. Should be given in any patient with this condition, high coagulopathy and increase in the serum transaminases. Because N-acetylcysteine has a beneficial effect even in those patients without a paracetamol overdose in other causes. It can decrease the progression to liver injury, and it can have also a beneficial effect on organ dysfunction, especially if it's given early. These beneficial effects can be mediated by its antioxidant effect, delivery of sodium load. It has also anti-inflammatory mechanisms, and has also a vasodilator effects at improving the microcirculatory flow. So in cases of non-paracetamol ALF, N-acetylcysteine did not improve the survival overall, but they found that it did improve the outcome in adults with mild grades of hepatic encephalopathy. And it should be noted that it's better to use it not more than 5 days, because they found that after 5 days, its anti-inflammatory effect will not be of benefit. The other less common causes, such as other drugs toxicity, we have known drugs that are hepatotoxic, such as anti-tuberculous drugs, chemotherapeutic agents, statins, non-steroidal anti-inflammatory, phenytoin, carbamazepine, and others, recreational drugs such as ecstasy, and so on. There are many drugs that are known to be hepatotoxic drugs. This issue is a big issue. It needs actually another talk to talk about deadly drug-induced liver injury, and it has many details. Acute Budd-Chiari syndrome, characterized by abdominal pain, ascites, hepatomegaly, loss of hepatic venous signal, reverse flow in portal vein on ultrasound. Wilson disease, characterized by young patient with Combs negative hemolytic anemia, Kaiser-Fletcher ring, markedly increased in urinary copper. Malignant infiltration, extensive malignant infiltration of the liver can cause ALF. This patient will have a history of cancer, massive hepatomegaly, elevated alkaline phosphatase, and positive tumor markers in some patients. And we have also another issue, which is pregnancy-related acute liver failure. There are 2 hepatic emergencies which occur in the usually 3rd trimester of pregnancy, can lead to acute liver failure, which are hemolysis, elevated liver enzymes, and low platelets, HELP syndrome, and acute fatty liver of pregnancy. Acute fatty liver of pregnancy, characterized by extensive hepatic steatosis by ultrasound, and usually present with abdominal pain and malaise. And transaminases level here is usually not so high. Hypoglycemia is common with elevated urate levels. Usually the actual treatment of this patient is immediate delivery of the baby. This will give a very good outcome, and emergency transplantation in these cases is rarely needed except in cases with persistent elevation of lactate levels, and if there is a severe hepatic encephalopathy that does not respond to treatment. Another cause, which is acute ischemic injury. This condition is characterized by marked elevation of aminotransferases, and of course there will be increased lactic dehydrogenase and creatinine due to hypovolemia. And luckily, these patients usually normalize after stabilization of hemodynamic status. Usually this happens with patients with severe congestive heart failure or respiratory failure or severe hypovolemia. Mushroom poisoning is not common here, but it can happen usually in Europe and USA. This patient is characterized by severe gastrointestinal symptoms and development of early acute kidney injury. Autoimmune hepatitis, usually the presentation here is subacute. We may find positive autoantibodies, elevated globulin, characteristic lymphocyte pattern. The early treatment with steroid in these patients may be effective, but lack of improvement within 7 days should lead to listing these patients for emergency liver transplantation, because prolonged use of steroids can lead to septic complications. And lastly, in many patients we can find a cause, and this is indeterminate etiology. So what about the management of these cases? The first step is, of course, a comprehensive clinical assessment and history taking from the patient and his relative that may help to diagnose the cause. We have to rule out the presence of cirrhosis and or alcoholic-induced liver injury. In these conditions, we can indicate liver biopsy. Liver biopsy can be indicated, although it's limited in acute liver failure. And if we are going to do it, it's better to be done through the transjugular route for fear of bleeding complications due to coagulopathy. We have also defined the interval between jaundice and the hepatic encephalopathy, and we have to search for etiology, because it's not just important for prognosis and treatment strategy, but also it is important for if there is indication for liver transplantation. From this table, we can find that some causes are related, which the emergency transplantation may be a treatment option, such as drug-related causes, acute viral hepatitis, Budd-Chiari syndrome, and many of the causes. But still, we have causes in which emergency transplantation is not a treatment option, like these patients with ischemic hepatitis, because once we stabilize the hemodynamic status of these patients, usually the liver functions recur back to normal. Also, the patients with liver cancer, extensive liver cancer, they will not benefit from liver transplantation. The second step is a comprehensive laboratory analysis at admission. We have to do lab investigations for assessing the severity of the disease, complete liver functions, renal functions, arterial blood gases and lactate, and arterial ammonia. We have to search for etiology also by doing toxicology screen for paracetamol, by doing serological screening for viruses, autoimmune markers, and also search for the complications such as serum lipase and amylase if there is pancreatitis. The most important complication is multiple organ failure. So management مفيش وقت. هو الموضوع كبير بصراحة فأنا حابة. لا كتير لسه يعني. طيب هختصر. هو المانجمنت اوف اورجن كومبليكيشنز we have many organs can be affected وانا هتكلم بس على الموست امبورتنت هو neurological complications. In cases of hepatic encephalopathy, lactulose or rifaximin have no evidence base in ALF according to the EASL guidelines. In patients with grade 3 and 4 encephalopathy, intubation should be taken to avoid aspiration. Gastrointestinal management. طيب هفوت كل الكومبليكيشنز.
خلاص الدعاء.
تمام.
خلاص conclusion. عايزين نسألك أسئلة بقى.
أيوة حاضر. وبعد كده الجزء بتاع الليفر ترانسبلانتيشن اللي هو طيب خلاص تمام هتكلم عنه. حاضر اتفضل. خلاص كده تمام.
حد عايز يسأل أسئلة يا جماعة؟ طيب قول يا دكتورة دعاء الجهاز بتاع